Good afternoon. I want to thank you all for coming today and attending this meeting. We have a hearing only on Dushan's the anticipated legislation on a muscular dystrophy disease of infants. So we're going to have some presenters here in a few minutes on that. And then we're going to do the bill on the radiology assistants, and then the laser bill. We'll finish up with that. That's Representative Silcock's bill. Just a couple of announcements. There's going to be a committee dinner on January the 23rd. I think y'all have got a notice on that already, an email. If you haven't, it should be in there. Also, to the group, if we have any amendments or substitutes, we prefer that you give that to Morgan Hall 24 hours before the meeting, so we have some kind of resemblance of sanity. Also, as far as public comments, if people would like to make public comments, let my office know before the meeting, so we can arrange that. We have members that are on multiple committees, and so I try to always hold these meetings to 2 hours. We actually think ahead and try to figure out how long this is going to take. So this would be much more workable for us in that way. Now, go ahead and start off. Are you ready with the video system up? Okay, we got Nikki Armstrong and then Alpha Kushani. I'm not sure who we got up first.
My name is Nikki Armstrong. I'm a genetic counselor with Parent Project Muscular Dystrophy, and I'm going to be talking about newborn screening for Duchenne muscular dystrophy. I'm pulling up my slides right now, so hopefully you all are able to see those. Give me just a second to get to right viewing mode. Can everyone see my slides?
Oh, yes.
Okay, great. And sound is okay? Anything you need me to do differently there?
No, everything's coming through well. Thank you.
Perfect. So like I said, my name is Nikki. I'm a genetic counselor by training, and I'm the Associate Vice President of Community Research and Genetic Services at Parent Project Muscular Dystrophy. Parent Project Muscular Dystrophy is an advocacy organization around Duchenne muscular dystrophy, and our mission is to end Duchenne. And we do that by supporting a number of pillars, which you can see on the screen here. But the one that's really important that we're talking about today is the importance of diagnosis of the condition Duchenne muscular dystrophy. So for those of you who aren't familiar, Duchenne muscular dystrophy is the most common pediatric neuromuscular disease, and it starts in early childhood. It's a genetic condition, but most people are the first person in their family to have it. Sometimes there's a family history, but many times it's a brand new genetic change in either the mother or the baby. Typically, it's diagnosed around age 5, although the symptoms start long before then. It's X-linked, which means it primarily affects males, although females can have symptoms in childhood, and some females can have more symptoms when they're adults. It's a muscular dystrophy, which means it primarily affects the skeletal muscles, but it's also a multisystemic condition. So we see effects in the heart and the lungs and in the brain of some people, as well as in the urinary tract and the gastrointestinal tract. The whole body can be affected in Duchenne. Duchenne is a progressive condition. So over time, people with Duchenne lose the ability to do certain functions. And I'm going to talk some more about that. Historically, Duchenne has been a condition that is 100% life-limiting, with most people with Duchenne dying by their late 20s. So this slide is just showing what has typically been the progression of Duchenne in the past. And what we see is most people with Duchenne are diagnosed around age 5 because they start having very specific symptoms. They might have a really hard time getting up off of the floor or climbing up the stairs or jumping or riding a bike. And then as they get a little bit older, those things become even more difficult. And things like walking a long distance can get really hard. They might start using a wheelchair some of the time. Historically, we used to see most kids with Duchenne lose the ability to walk in their early teens to mid-teens. And as that progression goes on and they lose their ability to walk, they also might have a harder time using their upper limbs. So doing things like brushing their hair or brushing their teeth or feeding themselves become more difficult. Throughout the teens and as kids get into their later teens, they might have more difficulties with breathing, especially might need some breathing support at night. And they might need more help with their general activities of daily living. And then during the late teens and into the 20s, the heart and the lungs are even more affected. And those are the primary causes of death with Duchenne. So Duchenne is a condition that has what we call a diagnostic odyssey. And what that means is that most families start noticing symptoms around 2 or 3 years of age. The first symptoms they notice aren't very specific, but in most cases, families will notice something about their child, like maybe the gait is a little unusual, or maybe they've had some developmental delays. And they'll mention those things to their pediatrician or their primary care provider. And there have been multiple studies that have shown that most families then take another 2 years to get to the diagnosis of Duchenne. And this actually, we've known about this for about 30 years. And so there have been many efforts to try to reduce this age of diagnosis and reduce this diagnostic odyssey. Those efforts have included the Centers for Disease Control, the American Academy of Pediatrics, as well as advocacy organizations like PPMD, but they have not been successful. We also know that children who have other diagnoses that can go along with Duchenne, like autism, are likely to be diagnosed even later. So their average age of diagnosis is over 6.5. And we know that children who are from underserved populations, children of color, are also more likely to be diagnosed at a later age. And these are issues because a long time of a diagnostic odyssey is very hard on a family. It's hard emotionally and financially. And there are also issues because one of the therapies for Duchenne actually has a very specific time window and when it can be administered. So I'll talk a little bit more about that. For those of you who aren't familiar, what we are hoping for with Duchenne is newborn screening. Newborn screening is the most successful public health initiative. Almost every single baby in the state of Georgia and throughout the US is screened through newborn screening. And really what the purpose of newborn screening is to identify babies that have conditions where there's a treatment for that condition. And that treatment is the most beneficial, the most effective, if we can start it early in that baby's life. Duchenne meets those criteria. And here's why newborn screening for Duchenne is really important. Duchenne is a progressive condition. It gets worse over time because people with Duchenne lose muscle over time. So we need to start therapies early. And right now, Duchenne has 7 FDA-approved therapies. So there are many different options for people. Duchenne is also very common, at least for a rare genetic condition. About 1 in 5,000 males at birth have Duchenne. So that's about 1 in every 10,000 babies. That's actually a lot more common than most of the conditions that are on the current newborn screening panel. And then the last piece is there's an effective way, a very accurate screen and process that you can detect babies with Duchenne through newborn screening. The first step of that process is a blood test that's done on the standard dried blood sample that every baby gets as part of newborn screening for a biomarker that's called creatine kinase. It's something that's elevated in people who have muscle damage. And so it works very well to identify babies with Duchenne. And then you can follow that up with diagnostic testing. But I'm going to talk a little bit more about each of these. So in order to understand why Duchenne is progressive, I think it's kind of a little bit helpful to get some background information. And also I'm a genetic counselor, so I have to mention the genes and the proteins. So it's important. So Duchenne is always caused by a lack of the protein dystrophin. And in this image, dystrophin is the purple beads on a string there, essentially. Dystrophin is really important in lots of parts of our body, but in our muscles, it actually works as a shock absorber. So when I talk to families, I talk about the fact that when we use our muscles, we have to expand and contract our muscle cells. And that's actually hard on the muscle cells. So dystrophin works to stabilize the muscle cell membrane during that expansion and contraction. That's a normal part of all the activities we do every day. For someone with Duchenne, they don't make any dystrophin. So as they're growing up and they're using their muscles and expanding and contracting their muscle cells, that's causing damage within the muscle cell membrane. And over time, that damage accumulates. And as there gets to be more and more damage to muscle cells, the muscle cells eventually die. And as more and more muscle cells die, that actually causes the muscle fibers to die. And then eventually that causes the symptoms that are part of Duchenne. This image here is some muscle biopsies. So this is muscle cells underneath a microscope. On the left is a sample from a baby with Duchenne. And that actually looks like a fairly normal muscle sample that's on the left of a baby. On the right is a sample from a child who is 3 who has Duchenne. So 3 is before we would typically have made a diagnosis of Duchenne. But at 3, there's already significant damage to the muscles here. So all of that white that's there, that's not normal. That's replacement of muscle cells by fat and fibrosis. So by the time we've gotten to age 3, which is before the typical age of diagnosis, we already have significant damage. By the time we get to 5 or even later, there's even more damage there. And that damage gets to a point where it's irreversible. We know that Duchenne actually starts before birth because we can see the signs of this muscle damage with the elevated CK and on the muscle biopsies. So it's really important that we're initiating and have the option to start therapies as soon as possible after birth. And this sort of a complicated diagram, but essentially what it's showing is that initially the muscle damage that our cells get, our body has a way to fix that damage. We have a way to, our immune system cells come in and we can repair that damage. But over time, the damage becomes irreversible. The muscle cells get replaced by that fat and fibrosis, and then the muscle cells die, and we don't know of any way at that point to then intervene and fix those muscle cells. So there's essentially a kind of a point of no return, and we want to be able to initiate treatments before that. At this point, like I mentioned before, there are 7 FDA-approved therapies for Duchenne. So at the top column there, the columns there, they're split by the different types of therapies. The first set of therapies there listed are exon skipping therapies. And those are therapies that are based on a person's genetic variant. So not all kids are eligible for them. It's only about 30% of kids that are eligible. But they are approved for every person who has that type of genetic variant. And they are appropriate for babies on through adulthood. The next category of treatments are what we call steroids, and they help with inflammation that is part of Duchenne. 2 of the steroids are specific to Duchenne, and they're FDA approved in kids 2 and older. And then the third steroid is approved at all ages. And those steroids, any person with Duchenne can have those steroids. And then the last therapy I mentioned is the gene therapy here. Gene therapy is a little bit unique in that it has a very tight time frame for which it's currently approved. So right now it is only approved for 4 to 5-year-olds. And that is a major issue in a condition where the average age of diagnosis is 5. Because if the average age of diagnosis is 5, this means that there are a significant number of kids being diagnosed at 6 or even later than that. And that means that at the time of diagnosis, they are not eligible for the treatment. And since we know that the diagnosis is not equitable, this means that we're also getting a skewing in who's eligible for this therapy, which is really, really unfortunate. None of these treatments are a cure for Duchenne, but what all of these treatments do is they slow progression of the disease. They add years. They add years of walking. They add years of breathing better. They add years of life. And those are very, very important things to people with Duchenne and their families. While we have these 7 FDA-approved therapies, we also have a number of other potential treatments in the pipeline. So this slide is just showing all of the current ongoing clinical trials and approved therapies in Duchenne. Anything that's going to the top of the bar graph is already approved, and the other things are sort of in different stages along the way of being tested. But what this essentially means is we have 7 good therapies now, but we expect there to be even more therapies in the near future. In fact, there's one under FDA review right now, so lots more to come for Duchenne. And while the pharmaceutical interventions are really important, another thing that is equally important are early intervention services. Kids with Duchenne have motor developmental delays. Physical therapy can be really helpful to them, but something that's also really important is that physical therapy in a person with Duchenne is approached very differently than physical therapy in a person who has low muscle tone for other reasons. So knowing the diagnosis and providing the appropriate physical therapy is really important. In addition, people with Duchenne have an increased risk of cognitive concerns, language delays, behavioral concerns, and autistic features. And because of those issues, speech therapy, behavioral therapy, and autism interventions are incredibly helpful. And they're most helpful when they're initiated early, both for the child and for the family's ability to communicate and to bond. So I mentioned before that Duchenne is actually, for a rare disease, a very common condition. Given that Georgia had around 124,000 births in 2021, we would expect that there were 12 babies born that year and probably at least that many in most years in Georgia. So this is an issue that will actually affect a fair number of families within your state. I also mentioned that there is testing that's very readily available for Duchenne newborn screening. So the first tier, the first part of the test would be that biomarker for muscle damage that we call CKMM. There actually is a kit that has been made to do this testing that the FDA has authorized, so it's readily available. And it's run on equipment that newborn screening labs have routinely. So it's the Revvity GSP equipment that is routinely used by newborn screening labs. There are a couple of potential ways that states can choose to screen for Duchenne. Some states do the CKMM and then they follow that up with the genetic testing, which would confirm the diagnosis. Other states will do a CKMM and then actually do a repeat one when the baby is a week or two old to verify that the CKMM level stayed elevated and then do the DNA testing. Both of those algorithms are very reasonable and just depend on the state's ability to do DNA testing and the preference within the state. One of the big questions we get is about the cost of newborn screening for Duchenne. And the exact cost depends on which one of those algorithms a person chooses, as well as the cutoff. But the best estimate is about $8 per baby. That cost includes the laboratory kit, the running the analysis, all the labor, as well as the referral process to the specialty care clinics that would follow up the baby after the newborn screening. I think it's incredibly important to remember that there's also a cost to not doing newborn screening for Duchenne. The Every Life Foundation did a study to look at costs related to diagnosis and to the diagnostic odyssey. And what they found was that per family, the cost of a delayed diagnosis was more than $200,000. And that included both the medical costs of going to appointments, trying to find a diagnosis, ER visits, and the productivity cost, the cost to that family and losing the ability to go to work on those days that they had to do those appointments. Overall, they saw 20 lost days of work for the caregivers per year and 17 out-of-state trips for medical care. So there were costs both to the family and to the society at large by having this delayed diagnosis that we see as part of Duchenne. Right now, we have made some great efforts towards newborn screening for Duchenne. So we have 2 states that have legislated newborn screening for Duchenne. That's Ohio and New York, both expected to start universally screening this year. Minnesota's Newborn Screening Advisory Committee has approved it, and they are in the process of moving that through. And we also have legislation filed in 2 other states in the US. So there's been a lot of progress made with Duchenne newborn screening. Then at this point, I'd like to turn it over to Alpa to talk about her story.
Thank you, Nikki. Am I coming through clearly?
Yeah, we hear you. Go ahead.
Thank you so much. Good afternoon to the members of the committee. My name is Alpa Khushalani, and I live in Fayetteville, Georgia, with my husband and 3 sons. Thank you for the opportunity to help you understand the impact that adding Duchenne to the newborn screening panel will have on families like mine across the state of Georgia. I would like to share the story of my oldest son, Krishna, who is 16 years old and has Duchenne muscular dystrophy. Soon after his birth, he was diagnosed with a right club foot and also had a hole in his heart, at which time he went through several panels of tests to find any other issues, but none of them indicated or any signs of muscular dystrophy. Basically, when it comes to the most common gene-linked disorders in boys, there is no screening requirement at that time. The result is that families like mine experience long and painful road to diagnosis, unlike those with less common but still routinely tested disorders. Growing up, Krishna was quite behind on his gross motor development. He couldn't hold his head up until he was 6 months old. He needed support to sit, and he only commando crawled at around 10 months. And so he was started on physical therapy through the Babies Can't Wait early intervention program to strengthen his muscles, which, as Nikki explained before, is not recommended for boys with Duchenne. They need very specific therapy to retain their muscles. Fast forward to him being 6 years old, and along the way, all of his missed milestones, for example, not being able to jump or climb stairs or alternate feet, he was constantly falling and was not able to run with his friends or even his younger brother. And all of this was being dismissed as possibly fatigue because of the hole in his heart or his partially fixed clubfoot. It was only when he was close to 7 years old when we saw a new orthopedic specialist in Chicago who determined, seeing him, that he needed to see a neurologist. And immediately, as the neurologist saw him, gave us a genetic test, and it was confirmed that he has Duchenne. No parent is ever going to forget the first time they learn of this diagnosis, and possibly can never forgive themselves or stop feeling guilty for the numerous times that we have pushed our children to stop being lazy, not use a stroller, and ask them to keep trying harder at sports and play. That child is growing with not proper care and isolation while the parents are in agony and frustration. Our story is very representative of the delayed diagnosis costing several hundred thousands of dollars, as we already learned, per patient, by which we have irreversibly damaged their muscles. Had we known his diagnosis at birth, we could have started intervention earlier and got appropriate care for him. Fortunately, this was not the case for Ren Howard from Macon, Georgia. Ren was diagnosed at 2 weeks old because his mom was a carrier and had a brother with Duchenne. An early diagnosis empowered their family to get Ren the necessary care at an early age and have better understanding of his disease and its effects. Ren right now is 13 years old. He has full ambulation and is doing very well. As difficult as his diagnosis was, Lisa is very thankful that it happened when he was an infant and that they did not have to take years to determine what he had. Despite these advancements in Duchenne treatments and intervention that you saw earlier, the average age of diagnosis is 5 years old. History was made this year when Elevidys, which is the gene therapy, which was approved by the FDA, but it was only approved to treat boys between 4 and 5 years of age. A veteran family from Columbus, Georgia, shared with me that they have 2 boys, Jacob, who's 11 years old, and Hudson, who's 7 years old. Jacob was diagnosed at the age of 5 after a 4-year quest by his parents, Ryan and Brooke Salmon, to figure out what was wrong with him. And after that, they tested his younger brother, who was 14 months old, Hudson, who was also found to be affected by Duchenne. 3 years ago, Hudson received gene therapy as part of the clinical trial, and Jacob could not because of his age. Despite both brothers having the same mutation, they both have very different trajectories today. Hudson is part of the local baseball league and is doing extremely well. An earlier diagnosis for Hudson allowed his family to get him the necessary care and gene therapy treatment. If you look at this picture on the screen, it's a very small representation of the different ages and stages of Duchenne. Do you know this little boy in the second row with the GA Bulldogs shirt is 8-year-old Henry and is in the same class as Representative Lee Hawkins' grandson, Edward. Henry uses a wheelchair at school and has limited ambulation. And I'm sure as grandparents and parents, you all can appreciate what it feels like when all your other peers are running around fast and enjoying the playground. Henry's older brother, Will, is also in this picture on the left next to Henry. He's 20 years old and he has lost complete muscle tone in his back and requires assistance with all his activities of daily living. Each of these boys and hundreds of more in Georgia may be on a different trajectory, but we have an opportunity to save every future of Duchenne. We no longer just have hope. What we have is real and meaningful therapies that can change the course of this disease. But time is of essence to receive this life-altering treatment. As you heard, FDA is only allowing the gene therapy to be given at this time to boys between age 4 and 5. So today, I wanted to be there personally, but my son Krishna recently fell in the bathroom, and he has been, he is recovering from that fall. By the time you're 16, these are difficult ages, and and we are working to regain some of his mobility, and so I was unable to be there in person. I apologize for that. As you consider the addition of Duchenne muscular dystrophy to our state's newborn screening panel, please remember the profound impact this test would have had if Krishna and Jacob were diagnosed early. Their quality of life could have been different, like that of Ren or Hudson, just by doing a small sampling of their blood. It is not an intervention, but an inexpensive test that is already routinely performed. Thank you so much for allowing me to share this story. As you know, several states have already legislated adding Duchenne to newborn screening, and I truly appreciate the chance to give other parents information and ability to fight for their children since the very first days of their lives. Thank you so much.
Thank you. And I want to thank you both for taking the time to speak to the committee. This is a very important issue. Years ago, we addressed Krabbe's disease, similar type of thing. Very rare, could be diagnosed with a heel prick on the newborn screening. So the legislation now is in the works, and we don't have that yet. I think Representative Karen Mathiak, you're going to be carrying this bill, correct? Okay. So today was for information only, but we will be seeing this legislation during this session. Okay. Thank you both very much. Okay. Up next, Becky Riles with the Medical Composite Board licensing for radiologist assistants. If you come forward, we heard this legislation during special session. We heard from Dr. Lee Martin, who spoke to this. So today, Becky will address this again for those of you that were not here then, and we will be voting on this bill today. Okay, Becky, go ahead.
Thank you, Mr. Chairman, members of the committee. I'm Becky Riles, representing Management Services Network. MSN is a Georgia-based company and have practices in Georgia as well as across the country that they manage their billing and coding, and also just work to increase the efficiency of the practice management for both improving the healthcare delivery system as well as the quality of care and the experience for the patient. Before you today is House Bill 434. Thank you, Mr. Chairman, for having this heard today. We have heard from Dr. Lee Martin as well as Dr. Joe Birch last session, if y'all can think back that far to their presentations about RAs and radiologist assistants and what they mean in terms of increasing productivity for radiology practices. A radiologist assistant is first a radiologic technologist who has been practicing, and then they choose to go back to school in order to provide a career path, or they could continue being a rad tech for the rest of their healthcare career. But for those who are interested in advanced learning and moving to a mid-level healthcare provider, then they go back to school for 2 years to learn how to assist a radiologist in imaging procedures. So this legislation is very clear that the radiologist assistant work only with a radiologist. So they are not trained to work with other specialty providers. Only radiologists practicing physicians. And then they do a lot of the prep work with the patient. So for example, if a patient is coming in for a biopsy, let's say for a kidney, the kidney has to be measured. There have to be a lot of data points that are already filled in prior to the procedure occurring to make sure that the radiologist is as informed and ready to do the procedure when he or she walks into the room. A radiology practice without a radiology assistant, of course, that's all done by the radiologist. So you can imagine with an RA who is helping to prep the patient so that when the radiologist comes in, the procedure is ready to be done. That means the radiologist can go back to that dark room and continue interpreting the other studies that have occurred in the course of that day. And so what this means are quicker results for patients. So those who are going in for a biopsy, hopefully they don't have to wait too very long before they learn the results of that biopsy. So in short, this bill does three things. One, it increases the healthcare workforce in Georgia by licensure for radiologist assistants. RAs are currently recognized in statute as healthcare providers, but in working with the Composite Medical Board, they felt that their training and the work that they will do for a radiologist is commensurate with other mid-level providers. And so they, in discussion among themselves and through a vote of the board in September of 2022, they felt more comfortable if there were licensure, which allows us to then capture those healthcare providers in Georgia and also make sure that they are in compliance with the parameters set by the Composite Medical Board. And again, an RA will work only for a radiologist, and they will not interpret any imaging, and they will just work to improve the efficiency and productivity for the radiologist in that imaging practice. With that, I'll stop and answer any questions. Mr. Chairman.
You know, one of the issues that we're facing in a number of the specialties is the limit of schooling or availability for residency slots throughout the United States. So we're seeing some of the specialists adding to the workforce has become a problem, especially with the growing population in a state like Georgia that's attracting so many folks from around the United States. This is sorely needed. I mean, this was actually brought by the radiologists, which is refreshing because typically we have this fighting between, you know, the physicians and some of the ancillary groups, you know, dentist, hygienist. I mean, there's always something going on somewhere like that. So it's refreshing to have this, and I sure appreciate that. Are there any questions? And I hope there are, because we're waiting on Deborah Silcox.
Well, to your point, Mr. Chairman, I'm proud to have worked with you on this legislation in recognizing it's a new day, it's a new year, and it's a time for all healthcare providers to work together to increase our healthcare workforce,
Right.
but also very importantly is to retain our healthcare workforce. And this will do both. So for example, a radiologic technologist who's been working for a number of years, he or she may be looking to how to advance their healthcare career. And currently they could go to medical school or go to PA school or go to nurse practitioner school, but this allows them to stay in the field of healthcare that they chose because that's what they like and that's obviously what they are proficient in. And so it allows them to just advance that career path. And again, for Georgia, it allows us to keep more of our healthcare providers here in Georgia.
Thank you. Representative John Corbin.
Thank you, Mr. Chairman. Thank you, Ms. Becky, for the bill. Just one question on the Georgia Composite Medical Board. Who makes that board up? Who appoints them? Is that something the governor appoints, or is that the way that board's
Yes,
made
Mr.
up?
Chairman, they are appointed by the governor and they work to provide licensure for physicians and other healthcare providers in Georgia. They also oversee the protocol agreements between physicians, PAs, and APRNs. So they felt that it was appropriate that radiologist assistants are licensed in order to ensure that we are meeting the health quality metrics that we expect from our providers and our patients. And then also gives us that mechanism to do a better count of where these providers are and how we can better distribute healthcare providers in all parts of Georgia, rural and urban.
Thank you, Mr. Chairman. At the proper time, I'd like to make a motion.
I've got a few more questions, but thank you. Representative Schofield.
Well, thank you, Mr. Chairman, and thank you for bringing this. And this is a great step in the right direction. And Corbett stole my ass. I was going to say at the proper time, I'd like to make a motion.
All right. Hearing that, do I hear a motion to do
Second.
pass?
Second.
Here a second. All those in favor say aye. Although opposed? Congratulations, you got your bill.
Thank you, Mr. Chairman. Thank you, members of the committee.
Did you hit your-
You got your bills.
Yeah. Bill out. If y'all don't mind, let's just take a few minutes and give Representative Silcox a chance to get here. She's got a bill over in the Senate. And so she may be a few more minutes, but it'd be good to hear that today. Huh?
This is an ex post facto. Question. So it really doesn't matter what you say because it's already passed. So you can tell me anything you want, right? If you look on there's lines 54 and following, it says the rules and regulations, the scope of practice, which does come up here once in a while. We hear, and then it goes down. It does have the word shall at the end of line 55. Does that in any way restrict the medical board? Let's just say one of these organizations, or maybe all of them, decided to change something, either the educational qualifications or the scope of practice. Does the word shall in there, or do we get away with it because of the word, the line 58, any other entity deemed appropriate by the board? Are they bound to change the rules for Georgia licensed radiology assistants just because one of these organizations changes their rules? Because I don't know all these national organizations. I'm sure I know we get a lot of them in different areas of healthcare that can sound official. Some of them are, some of them aren't. We get it with board certification and things like that. And so I'm just curious, or does the line 58, is that where we believe that the board still has the final authority because it's any other entity?
Yes, Mr. Chairman, you are correct. Line 58 does supersede anything else prior to that. And also this language is here to ensure that it is consistent with radiologist assistants, their training, and what their scope of practice would be in Georgia. And the Composite Medical Board has already discussed at length ways to make the parameters under which they will practice even more tightly written, so that we ensure that we don't get any outliers out there as it relates to RAs practicing in Georgia. I hope that answers
Thank you. I
your
know that,
question.
like you mentioned, healthcare workforce is tremendous, getting our radiologists. I appreciate the 62 and 63 as well, to make it clear that we're getting the benefit of those 5 or 6 years of training before they read an MRI or
Yes.
something like that. We don't want to after medical school.
Right.
So we don't want to shortchange the patients. I appreciate you putting that in there to make it clear that the interpretations, the diagnoses, things like that are still going to be required to be in the realm of the board certified or trained radiologists. But I appreciate it.
Yes.
Good bill.
Thank you, Mr. Chairman. And to your point, that language is here to make crystal clear that this radiologist assistant is designed and the licensure is designed to keep everyone in their appropriate lane, if you will. And the language in this legislation also makes it clear that a radiologist assistant is not eligible to go to training to become an RA and then go work for another specialty provider. because their training is so specific to imaging, it would not be appropriate for them to work for another specialty physician because imaging is all they learn. And so, and they learn in that additional coursework how to assist the radiologist and how to, again, improve the efficiency and productivity of that imaging practice. And as you all are aware, I'm sure, imaging is one of the highest volume specialty areas in Georgia. A lot of that has to do with technology, and it's not just Georgia, it's across the country. But more and more, imaging is used as a preventive tool, and as well as early detection, because of what that means for the quality of care for the patient. Not to mention the costs that would be incurred by a lack of diagnosis until later on during a serious illness. And so for those reasons, we wanted to be sure that those radiologist assistants who are coming to Georgia, you're here to work for a radiologist. And a lot of them also have that responsibility in training to find a radiologist to be a preceptor. So that radiologist also has to check off on the fact that they are proficient in performing the duties of a radiologist assistant even before they graduate from RA school. So again, the clinical components are there to ensure quality. And then once they are hired by a radiologist, that radiologist, it's incumbent upon them to make sure that they are proficient in the type of imaging that they will do. So whether it's musculoskeletal, whether it's, whatever oncology, radiologic oncology, it's going to be incumbent upon that radiologist to be sure that the RA is proficient in those types of imaging services.
Thank you.
Thank you very much. I think it's well said and very important. When I got out of dental school 44 years ago, most expensive x-ray was a chest x-ray, and that was about 50 or 60 bucks. Most physicians at that time would read their own x-rays taken in their office. But we have gone to a level now where there's so many specialty type of radiology techniques, and also the requirement for a specialist, especially doing something that could be a liable situation. Physicians are having radiologists pretty much do all of it now. Do you have another question? Your light's blinking. Oh, okay. All right. Well, I think that's it. All right. Thank you very much, Becky. I appreciate it.
Thank you, Mr. Chairman.
Okay, we got a few more minutes, I think, before Representative Silcox gets here. Yeah. Do what?
Ask another question.
You want to ask something? Is that what you're?
Discuss something on the bill that may be a question that we can think about before she gets here.
Yeah, well, that's fine with me. Go ahead. What number are you?
7.
Okay.
Maybe think about this. And,
Representative Sharper.
all right, thank you, Chairman. Okay, what we see on line 36, okay, we're talking about this individual being able to perform these different services. But then it says like the level of they no longer have to have the on-site supervision of a senior laser practitioner. Do you think it's necessary that if the senior laser practitioner is taken out of this, saying that they no longer need to be on site, do they really have to have, I guess, 38 through really anything mentioning about the senior laser practitioner?
I really can't speak to that. Representative Silcox and I have really not gone through this bill. Her husband is a physician, a well-respected orthopedic surgeon from Gainesville, Georgia.
Mm-hmm.
So that checked a lot of boxes for me, but also, but I tell you what, I think it's a good question. When she gets here, you can answer that.
Okay, because if it's basically, I mean, looking at the scope of it, you know, if they're able to do it, you know, I don't think the senior laser practitioner part really needs to be addressed. I'm gonna look at it even more, but I don't know why that part's even in there.
Okay. We'll have that discussion when she gets here.
Yeah, that's the current structure of the code section. So if you look at starting on line 24, that's the requirements for an assistant laser practitioner. And then when you get down to line 38, that's a separate set of requirements for a senior laser practitioner. So even if you strike the reference to the senior laser practitioner on line 37, you still need the requirements for generally for senior laser practitioners. If that makes sense. Mm-hmm. Yeah, it's two different licensure categories. So,
By statute code, I guess that's why it's in there, because
right,
other than that,
right. It's just setting out that whole code section or that whole subsection. So that just happens to be part of that subsection. So
Okay.
no changes to that. So.
that's cool.
Thank you, Betsy. Okay, all right.
And we're getting practice right here for
Another question.
because we're practicing for session. So while we got time, we rehearsing.
Right,
But
right.
anyway, but if we're talking about keeping things in under the subsections, we're here where it talks about a person to revise provision on line, good, let's go into line 3, relating to the requirements for applicants for assistant laser practitioner license to provide for related matters, to provide each state to repeal conflicting laws for other purposes. So even though we're mentioning that assistant laser practitioner licensed person, if we're adding in the other one about the senior, why aren't we adding anything about what the assistant laser practitioner is, what they do?
About the on-site supervision. So it's affecting the assistant laser practitioner's license requirements, but it's just set out because they chose to, or I guess I drafted this. It was, I could have just set out paragraph 1, lines 24 to 37. It just shows up in the bill because that's the kind of the level that I went to include the language. So even though it's referenced in here, there's no changes to that.
Right.
Does that?
Oh, yeah, but that's
Is that
good.
all?
Whoever did, approve this bill back then, that what the
Mhm.
issue then for us saying, okay, this the assistant going into that, but the reference of the senior being involved of the change of the on-site supervision changes. So, so that's good.
Okay. I hope I answered that.
All right, we're ready now. Is it passed? Done? No.
Representative Silcox, the lady with all the answers. And so do we have all the questions lined up now? Do you have that on the computer? You can slide down to her? All
I
right.
apologize.
No.
Chairman, I had a constituent, a good friend that I nominated to be a Superior Court judge, get sworn in after I was in the one with Mark, so I apologize.
So you're doing the Senate after this then?
Yes.
Because I told him you were in the Senate.
No,
committee.
I'm doing
Okay.
good.
All right. Well, you are up, and if you would like to discuss your bill, we are all ears.
Thank you so much. I, of course, come to present House Bill 502. And House Bill 502 is actually was asked for by the Georgia Dermatologists Association. And it has basically 2 parts. Then part 1, it updates the definition of cosmetic laser services in the Georgia Code to include all advanced dermatological treatments and includes ultrasound, cryolipolysis, and microwave. And so this basically is just, again, an update to the Georgia Code because there have been so many other new procedures, dermatological procedures developed that the previous definition did not encompass. The Section 2 revises the supervision requirements of an assistant laser practitioner by eliminating the requirement for a senior assistant laser practitioner to be on site with all of the workforce issues that we have, as well as more technology that we have. That person would still be supervised by the senior assistant laser practitioner. They would still be supervised by them, but they would not have to be on site, similar to other changes we've made in the code, like with the dentist. I know you're familiar with that, Mr. Chairman. So that is the bill.
So we have a question? Representative Newton. Okay,
Yes,
I'm
sir.
sorry. Chairman Gunter.
Representative Silcox, what's the significance of striking the language in lines 17 and 18 on page 2?
And that is 17 and 18. Oh, I think that is, again, because it previously, it was in the code previously, it just didn't fit with with the new definition.
Okay, so
It
it's taken
doesn't-
care of elsewhere in the code section?
Mhm.
Okay, 'cause I'm not familiar with this, so
Right.
why I asked. Thank you.
Mhm.
It's just also known as the melting fat bill. That's
I
really
think
what
I think that might.
a big part of this is.
Yes, it is. And I think that's what the cryolipolysis
That's what they do.
is. So,
Okay, any other questions? Hearing none, do I hear a motion? Do I hear a second? All those in favor, say aye. All those against? Congratulations. got
thank
the
you.
bill.
Thank y'all
you.
for the
And thank you to
committee,
the
your
committee for
patience. I
sticking
appreciate
in
it.
that. I appreciate it. Thank you very much. Yeah, Betsy's the best.